All right, good afternoon, everyone. I am Zach Hostetler, Chief Operating Officer here at Employers Health, and thank you for joining us this afternoon. I have a few items to note today before we get started. So first off, currently all attendees are in listen-only mode. Please use the Q&A function on the left-hand side of your console to submit any questions you have throughout today's presentation. We'll do our best to stop and address items as we go through the presentation, but if it's not an opportune time to ask the question, we'll try to get to them at the end. If we run out of time today, we'll make sure that we follow up with any individual that asked a question following today's call. A copy of the presentation is available for download and can be found by clicking the paperclip at the bottom of your screen. You should watch your email tomorrow for a recording of today's webinar. And upon exiting the webinar, you will receive a survey to provide feedback. We certainly appreciate everyone's feedback. It helps us to continue to shape our future programs and ensure that we're providing valuable content to you all. Next month, we'll host our last webinar of the year, The Future of Pharmacy, Navigating the Challenges Through Innovation. This webinar will discuss the key trends shaping the future of pharmacy and the innovations necessary to remain competitive in the market. You can find out more and register by clicking on the paperclip at the bottom of your screen. Lastly, I want to take a moment to invite you to our 2025 Annual Benefits Forum on April 22nd and 23rd in Columbus, Ohio. We'll have a great lineup of benefits professionals discussing the industry's hottest topics. You can learn more about this exciting two-day event and register on our website at employershealthco.com/ABF25. A link to this event can also be found by clicking the paperclip at the bottom of your screen. All right, and now to move on to the presentation. Joining me today is Jeff Zimon, founding partner of Zimon LLC and founder and CEO of EZ ERISA LLC. Jeff has more than 30 years of experience advising clients on all aspects of employee benefits, benefit disputes, and litigation. Welcome, Jeff.
Well, greetings. Thank you very much. Greetings to everyone in the presentation this afternoon. We're very grateful for you attending today. And we are going to be talking about what is not anything other than an extremely exciting topic, which is problem solving through documentation. So the idea is we're going to, in essence, overcome mounting pressures that exist with respect to the delivery of pharmacy benefits through proper implementation of guideposts and rules. So today, we're going to talk a little bit about the requirements. That's normally something that people think of as being the rules. And we're going to talk about the requirements not only with respect to ERISA governed plans, but we will touch on non-ERISA governed governmental and church plans. And we're going to talk about the idea that appropriate, more thorough and complete documentation is just not an option anymore. We will then also talk about what we're seeing people are doing, companies are doing, sponsors, and talking about why what is being done is just not going to cut it. It's not adequate anymore. We'll touch on mounting government scrutiny and litigation, and I'll even have a few comments regarding the transition in the federal government, the administration, which is changing in January, and I'll give you some reminders about what this to-be government was doing back in 2020 to send you a little bit down memory lane about what we think, based on what they did in 2020, they're probably going to be doing coming up as they take over the control of the administration. And then we're going to talk about what are the risks. I mean, so we haven't been doing stuff for a long time. Why do we have to focus on this kind of documentation and rule presentation now? And then we'll talk about a solution. And I think that's really the icing on the cake here is we're going to talk about an easy, simple, straightforward solution that we're delivering to end user clients through brokers and consultants that we are all working with. So we have an opportunity to review and discuss with many constituents, employer sponsors, brokers, consultants, and everything in between about documentation that relates specifically to a self-funded plan that separates pharmacy from group medical. And that's really what most of you are interested in this discussion for, is because your pharmacy benefits are being delivered through a different mechanism than your medical benefits. And in any event, you're using a pharmacy benefit manager arrangement that is separate and needs to be self-contained. And many folks don't really know whether they have the rules articulated, and many folks think that they might already have them. And so we ask, and we are discussing with constituents all the time about what may or may not be happening with their documentation. So what we find is most of the time, people have nothing. They have absolutely nothing. They're not really using much in terms of paperwork. There may be some flyers. Occasionally we see schedules of benefits, maybe a handout or two about some special services. And sometimes we see a little something that really isn't going to cut it. We see Band-Aids all the time. We see an attachment, a 7 or 8 page attachment, or a little packet of information that really just doesn't have the specific guideposts rules that we need in order to properly manage and control our pharmacy benefits. And we've seen some, not very many, that have invested a lot of time and money, and that's an option for everyone. There are benefit lawyers or ERISA lawyers throughout the country that have the capacity to do this. Not all of them have a large or deep experience with pharmacy benefits, and going to law firms that have this capacity usually means you're going to spend a lot of money and you're going to take a lot of time. But we often see documents coming to us with the question, what do you think of this, Jeff? How does this work? And we'll review any document anybody would like to have us test for you. And I can think in the last year, we really haven't seen anything that even gets close to documentation that would really help you manage your plan, in addition to complying with the rules. And so it's time to replace the nothing with something. And right now in the United States, EZ ERISA is the only company that's offering a comprehensive, we will tailor custom for you, a prescription drug benefit plan document and summary plan description that meets the requirement. And I will touch on governments and churches in case there are any government plans here. We have a document set that accommodates those non-ERISA plans. All right, so where do we start? Where's the fun of ERISA document solutions, right? I think of documentation not as compliance, because everybody would be asleep in 5 seconds. It's what are we doing to manage our plan? What are we doing to make sure that everyone knows what the rules are? From step therapy to you have to do potential foreign sourcing, patient advocacy, whatever the rules are, formulary designations, management of formulary designations. How do we get all this stuff compiled for folks? Well, the first thing is we can look to the legal basis upon which we are proceeding. Number one, ERISA has a plan document requirement. It's the law. And we'll talk about why folks maybe have not been focused on this for a while, but suffice it to say that every plan has to be maintained pursuant to a written plan document, and that's in essence a contract. A plan document is signed, it's implemented. And this definitely applies to prescription drug benefits when they are separated out from group medical. And just a note, sometimes the group medical provider may try to Band-Aid in some of the provisions that are necessary. But in most cases, they aren't putting the proper definitions in because they've already taken them out, knowing that you're separating your pharmacy benefits from your medical benefits. And again, the Band-Aid solutions and the little handout solutions really are not cutting it. The next thing that we all have to think about is a summary plan description. Now, most of you think of the summary plan description because that's the document that we're giving out. What we've decided is to combine those two requirements into a master so that the language makes sense and it's presentable, it has the pieces parts, but also meets the plan document requirement. This is a clear requirement for prescription drug benefits and their presentation. And we're going to talk in a moment about how important this is for purposes of all the really wonderful, creative, and thoughtful things that you and your clients are doing to get more involved in the delivery of pharmacy benefits and manage those pharmacy benefits. And by the way, I will pause after each sort of segment, check in with Zach, and make sure that there aren't any questions that might be appropriate to handle in the middle of the conversation, but we'll address any questions that come up as best we can based on the time. So if we take a look at these rules, one view of the world is, oh, we have to do this because we have to do this. Well, I don't like that answer. I very rarely like to talk about what we have to do just because we have to do it in the context of welfare plan design generally, welfare plan implementation generally. I want to translate these fundamental requirements into an advantage for our broker partners and our consultants and their end user participant companies. What do I mean by that? I mean that we're problem solving here. We have a problem. We want to provide really good prescription drug benefits. Prescription drug costs can be out of hand, out of control. Every time a new drug comes out, we get nervous about it. The Wegovy's and the GL1 management drugs, the Humiras and the Enbrels of the world that are high cost pharmaceuticals that really impact our groups. Right down to the day-to-day, where is the best sourcing for our day-to-day generic and or brand name drugs? We're working on many different angles of solutions. Many of our PBMs, those that we work with all the time, have their own set of solutions and their own set of programs, rules, and related strategies. And so the idea for me in documentation is to take that requirement and mold it around how we are going to use this documentation to better manage. And the first thing we're going to be able to do is communicate the rules in a better, more cohesive way, a compliant, better cohesive way, so that everybody has the rules. We're going to be able to describe the benefit provisions. We'll be able to show the deductibles, copays, and copayment amounts. That is what I usually see in handouts. That's usually pretty much all I see in the handouts. But benefit limitations and exclusions, really, really important, right? To me, one of the fundamental things that you do in these documents is say what we don't do, right? And we can link that to formulary designations and other strategies as well. How do people get the drugs? Sometimes in the handouts, but we often see a lot of special rules around special medications, special rules around orphan medications, special rules around certain brand acquisitions, special rules around formularies, special rules. And we think that's critically important that they be available to the individual participants, A, because we want to make sure all the guideposts are out there, all the speed limits and stop signs are available for people to see, and for us to be able to enforce, meaning to be able to manage and controls. Placing controls on these arrangements is critically important, both for ERISA and non-ERISA arrangements. Pre-authorizations, utilization reviews, special techniques for managing around the high-cost medicines, got to be there. It's got to be there. In fact, notably, and I may repeat this a few times, your pharmacy benefit managers, almost all of them, have a standard set of language that you have agreed to put in your documentation. And we'll, of course, put it all in there. We have all of that standard language. We'll add that standard language to your agreements and documents. But it's very important that you have it. A, because you promised the PBM you'll do it, and B, because that helps solidify and establish how we are controlling and managing all of our strategies. Network and in-network and out-of-network rules, copays, deductibles, any connections between pharmacy and medical. Do we accumulate deductibles and copays together? How does that all come together, right? And we will do all of that. And COBRA and claims procedures, it's funny. I look at various samples over time, and one of the most important things is to be able to have a claims process. Really, really critical. And the handouts don't tie to a claims process. They don't. And sometimes you might see it if there's a medical document out there, or sometimes we can push a claim over to a medical plan, but most of the time, it's just not there. And we may put the person in COBRA for purposes of the group medical, but if there really should be some language out there just to make sure that we're touching all of those bases. Now, for our friends on the call who are brokers, consultants who work with government plans, and there are a lot of them, and for those potential clients who are on this webinar this afternoon who are in government or churches, as you know, you're not subject to the ERISA law. We knew this going in, and we find it is equally important to do all the things that we're saying in the context of ERISA to our friends in the government plans and church plans. And while those plans are not specifically subject to that ERISA law, they need to have enforceable contract arrangements, right? They need to have controls, right? They need to be able to tell their public, whether you're a school board and a public school, whether you're a city or government unit or some other quasi or actual government unit, you need to be able to show your constituencies that you have put controls and management around these expenditures and have the capacity to defend against any claims or defend against any government inquiries. And even if you are a government unit, you can be investigated by Centers for Medicare and the Health and Human Services area, just like anybody else can. And while the Department of Labor doesn't have jurisdiction there, you have Health and Human Services. And so, in fact, in some jurisdictions that we've encountered, the failure to provide appropriate documentation is actually either a violation of state law, some of the accounting rules under state law, or local ordinances, and tie those into school boards and related organizations, charters, and other organizational documentation that requires certain types of contracts and documentation. And candidly, the participants also deserve, and this is one of those rules that applies across both the ERISA and non-ERISA sphere, the participants deserve a single source, a booklet, a piece of paper they can pick up, even if it's electronic, and take a look at when the person in human resources says, well, there's an exclusion for that, and it's on page 10, and there it is. Or you have to follow this specific procedure with our PBM, and it's on page 37, right? And so the person can take it, and it solidifies their understanding that these rules actually exist, and the rules actually apply. And I haven't said the word compliance in a bit. Remember, it's not about the compliance at that point. It's the idea that we're giving our people a single cohesive resource to be able to find a rule and be able to understand that it's a real rule, and we're not just shooting from the hip or making it up as we go along. So if anybody has any questions about some of these basic fundamentals and how they tie in, you should feel free to hit the Q&A box, and we'll do our best to answer those questions. Unless Zach sees anything, we're just going to move on to our next section, which talks about the idea that existing approaches don't work and they're not adequate. So, question: we haven't done anything for years. Why are we focused on this now? Well, we are employing, all the collective we, our broker partners, our consultants, are coming up with new strategies and new ideas. We have task force, we have teams. Many of our broker partners have specialized units. Our Employers Health Coalition team has pharmacists, internal teams, negotiators, a robust set of people focused on management and control and delivery. So we're not talking about not delivering pharmacy benefits. We're talking about delivering pharmacy benefits in a managed, thoughtful, appropriate way. And because we're employing these tools, and many of these tools are excellent tools, not only to be able to provide delivery of the pharmacy at the end user, but also to be able to make sure we can monitor, manage, and account for what it is that we're doing. But you really have to be able to show those rules. You have to articulate them and show them. And so my starting point, instead of harping on compliance, is, look, we've got stop signs. We have road signs about which way you go and how you get from one place to another. We have maps. We have maps on how you get your drugs and where do you source it and how you source it and who you have to talk to. We have all of these rules. And if we don't write them down, your people lose faith in them and they begin to challenge them, but also you can't really enforce them. So that's one thing. The second thing is substantially increased government scrutiny. And so if anybody doubts that, I'm happy to talk with you on the side, but I'll comment on this very briefly here, maybe mention it again in a bit. So the current administration is clearly focused, and the new administration will be focused. And I have some slides later where we're going to drill in on that a little bit. There is going to be maintained government scrutiny from Department of Labor, from Health and Human Services, and from state and local governments. We have increased litigation risk, and we're going to talk a little bit about that as well. And we have increased risk to our plan sponsor and to our brokers and consultants if we're not sort of managing around these rules. Question, we use flyers and handouts, and we've been doing this. Why do they not work? Well, fundamentally, they're just not adequate. They're inadequate. They miss many, many things. They lack certain basic information. They lack prescription drug management rules we talked about. They miss definitions. They miss formulary designations. They miss some of them even miss how you exactly connect with a pharmacy benefit manager. I've seen some that are just unbelievably incomplete. Exclusions, limitations, and of course that pharmacy benefit manager required language, which is so really fundamentally important. But I think fundamentally you also have to think about we're protecting everybody. We're protecting the constituent end users by giving them the rules and guideposts so they know what is in, what is out, and how. How, where, when, how much, how does it integrate? And having all of that in a cohesive, compliant place is a good idea, but it's really important for purposes of those the people who are receiving this information, to have a place they can look. From the company perspective, we talk a lot about controls, but there's another feature that is mentioned in this list that I want to talk about, is the fiduciary responsibility. The fiduciaries of a group pharmacy plan are the administrators, and anyone who can approve or deny a claim have a fiduciary obligation under the federal ERISA law to ensure that there is documentation and that the documents are followed. That's a fundamental aspect of ERISA Section 404, right? You have to make sure that the rules of the plan are being followed. And in fact, that is what you can enforce upon, aside from ensuring delivery. And that means that from a fiduciary liability and responsibility perspective, the fiduciaries, your plan administrators, really have to ensure that the documentation is there and adequate, that matches up with where you are. Question, our brokerage created and uses an attachment to the group health plan. Why should we do more? Well, Band-Aids don't work. If anybody wants us to look at a Band-Aid or an attachment document and we do a free cut, it's a service to our Employers Health Coalition community. Anybody, we'll take a look at any document and we'll run a checklist on it. And I was thinking back before we started today of some of the samples that we've seen. I have one sitting on my desk over here in the corner that was prepared by a national insurance brokerage firm. It was a good start, but it's only got about 25 or 30% of what it needs to have in it. And so we'll review them for you and tell you what is there and what is not there to help you understand. And if that helps process this decision-making with your end user plan sponsor clients, or you want to be able to have conversations internally about moving to the solution that we're offering here, we're happy to take a look to ensure that you have some comfort that the document doesn't work before you move to a document that does work. And we're happy to do those reviews. Many of them just lack a lot of the basic fundamentals of exclusions, limitations, integration with group health. And candidly, if you're doing a Band-Aid and you don't have sort of the lawyer license, or the right background and experience to be able to produce these types of documents, you're kind of exposing yourself a little bit. And I say that to internal teams at companies too, who sometimes try to take what they have and augment them on their own, human resource staff. And many of them know a lot of this, but it's better to have sort of a broader base of thought that goes into the preparation of these documents. Next question, what about the PBM? Why isn't the PBM doing this? Well, that's a great question, because if the PBMs did this, we wouldn't be having this conversation. And they would have been doing it for years, right? And I actually represent a couple of PBMs, smaller regional PBMs, and have over the years spoken at conferences and consulted with many of them. And we meet and talk with a lot of them at our various Employers Health Coalition discussions. And I think the answer is pretty consistent. This is not what we're in the business for. We haven't ever traditionally done it. We don't have the wherewithal internally to be able to produce it. So they don't want to be your ERISA experts. They don't want to tell you how to put your documentation together, but they'll help. They have lots of rules and they have lots of handouts and guideposts. But I think fundamentally they just have never been in the business of doing this, and because it's not insured, they aren't required by government regulators to produce documentation. So let's touch that for a second, because I think this will help everybody solidify why PBMs don't do this. If you are a third-party administrative firm, you're going to have documents for medical because of the way medical plans operate and because of provider relationships. If you're an insurance company, Anthem, United Healthcare, Cigna, Aetna, you have to have your documents approved by the state governments in every single state in the United States, because states still have control and regulatory capacity over insurance contracts, right? And so you're producing all these documents to the state regulators. Well, the PBMs don't really ever do that, because PBMs aren't required to, because either the insurance companies are doing it and then borrowing the PBM as their administrator, right? Or the PBM's going direct to a self-funded plan. So since the PBMs haven't traditionally had to file these with government agencies, that's another reason why they just have never built the capacity to do this. So hopefully that explains why we're really not getting this out of the PBMs. And because of all these other mounting pressures, the idea was, let's help get this done. And that really leads to why are we focused on this now? You know, ERISA is 1974. You know, I said to people, the Affordable Care Act was adopted in 2010. It took till 2013 before anybody was really able to think about doing anything. And it really took until 2015 before people started really focusing on it. Why? Because ACA was designed presumably to solve a problem. And then after the government does its legislation, it takes time. Well, now we see these mounting pressures. We see new expensive medications, pressure on the financial side. We see litigation. We see government getting involved, significantly higher cost concerns being raised, right? And so in our field, in the benefits field, the one constant is change. And the simple message I think is best is times have changed, things have changed, and we need to upgrade our approach to how we utilize documentation to support the strategies that we are putting into effect. We've talked about government scrutiny exams and audits. We've talked about pharmacy benefit management scrutiny. We've talked about new items, lawsuits, the Johnson & Johnson lawsuit, which I'll talk a little bit about in a minute. We've talked about pharmacy benefit managers and all new strategies coming out with new documentation. We've talked about updating our management approaches and controls. We've talked about making sure that our guideposts are there. And so really now is the time. Let's just touch a little bit on federal and state scrutiny. I'm going to actually start with state. I'm going to go to B first and then talk about A, because I want to get a little bit into A. So state government scrutiny. Now, what I'm going to say now is not intended to be controversial. The blue states and the red states have a very similar approach to pharmacy benefit management inquiries and the delivery of pharmaceuticals and costs. So Florida was focused on PBM licensing. Florida was focused on importing drugs from Canada. And there are more than 250 bills involving pharmacy benefit regulation that have been filed in the last period of time. And what you're seeing is a problem that needs to be solved, which is medicine is expensive. There's concerns about the way pharmacy benefit managers function, and we have to address that. From the federal government perspective, the 2021 Consolidated Appropriations Act required certain examination of pharmacy benefit managers. There's Senate hearings, et cetera. And I think that most of you would recognize that the current administration has been upgrading their approach to pharmacy benefit management, has been upgrading their approach to the control of data and flow of data and management of rules. The Department of Labor has commenced auditing. It's very scary when they start asking for lists of claims that are being processed. And so as the new administration comes in, I'm going to put you in a little time machine here. In the summer, in July of 2020, the administration that's about to enter, that was in power in 2020, President Trump at the time signed 4 executive orders directed at pharmacy benefits: an order regarding pharmacy benefit managers, and orders regarding controls of costs, and more. And that we don't believe is going to change. If anything, it's going to potentially accelerate. What they demonstrated in 2020 is that they see there's a problem that needs to be solved. And because they could not get enough participation out of Congress, the president at the time decided to issue executive orders. And I expect, and most people that I speak with, and I've been speaking with them very quickly because of the timing here, no one that I've seen and talked to has had any question that whether it's this administration or the new administration coming in, that government scrutiny and pressure is going to remain. And I think that's very important to understand. We need to be ready. We need to be prepared. And this is another way that we can help accomplish that. And if anybody doubts that there's increased pressure on this entire part of our benefit delivery, then I'd be happy to have a separate conversation with you about it. I want to touch base very briefly. I'm not going to get into a big, long working group discussion about the Johnson & Johnson case. But Lewandowski versus Johnson & Johnson is a game-changer piece of litigation. It's a class action, 75-page complaint, and the allegations focused on pricing and argued that Johnson & Johnson did not turn over documents upon request. Now, for those of you who are in this business, you know that the summary plan description requirement includes the requirement that it be disseminated within a certain period of time, right? And also under the ERISA law, upon written request, the employer has to produce the plan document and the summary plan description to any claimant who requests it within 30 days. If they don't, there's a penalty attached to that, right? And so, again, I'm trying not to focus on compliance. I'm trying to focus on our other reasons and purposes for doing this that make sense, other than you have to do it because you have to do it, because we haven't been. I'm talking about why I have to do it now. But apparently, Lewandowski had asked for the document, and it wasn't produced, or certain parts of the documentation wasn't produced. Eventually, it was actually produced in this litigation, and it is shocking how poor and inadequate Johnson & Johnson's own document is. Johnson & Johnson has 130,000 worldwide employees. It has over 60,000 U.S.-based employees, and they produced what I would describe as a Band-Aid. Johnson & Johnson is a manufacturer of pharmaceutical products as well, and their plan document, if you can call it that, summary plan description, if you can call it that, is more than inadequate. I would use some more colorful language to describe how inadequate it is, shockingly inadequate. And it doesn't even use the word formulary. So the presumption is that every single drug on the globe, on this planet, and maybe if there are any drugs over on the moon, are all covered by this plan with basically no management, because the documents that they produce to the court, along with filings and motions, doesn't mention the word formulary. And if that's I can't say more than that to give you the idea that even Johnson & Johnson wasn't producing documents that allowed for the management and control of all of this stuff. And so this is raising a lot of red flags. Now, of course, they're in the middle of a class action lawsuit, and Wells Fargo was recently sued in a similar case. So I say to everybody, it's time, right? And I remind people, most of the people here on this call with us are, probably health and welfare folks. If there are any consultants that do anything on the retirement side, or any of our customers that have retirement plans, that the class action lawsuits on fees, costs, and expenses in 401k and other retirement plans started over 20 years ago. And before that, that wasn't a big deal. And now it's a common occurrence that massive class action lawsuits get filed. And this is just the beginning relative to the delivery of pharmacy benefits. And so the question is, are we ready? Are we ready to deal with it? And I think there's nothing more that you need to say, really, other than we have to be prepared. All right, so quickie summary, and then I'll check in with Zach and just see if there's any questions that he thinks we should address at this point. So why? Well, it's a requirement of the law. All right, that's your boring answer. And it's true, it's a requirement. State law requirements for contracting, government units, et cetera, you really should have things in writing and to be able to manage and control. PBMs do. The ones that we work with have required language, so you need to have that presented to the participants. The Department of Labor can force you to do it, and there can be penalties. There is new enforcement initiatives being undertaken by the DOL. We don't think those enforcement initiatives, which are being controlled and run by career Department of Labor members as opposed to elected or appointed, we don't think that's going to change radically with the new administration, especially if it focuses on helping the people, because I think that's been the focus of even the prior administration. Participants can request it, and if they do, you have 30 days to produce it. By the way, speaking of that, when we get to it, we can produce this document in like a day if you need it. But don't wait. Please don't wait. Litigation. It's not surprising that you have an ERISA lawyer using the word litigation, but I think you all have seen the articles about the Johnson & Johnson lawsuit, and you know that it's out there. And again, we have our management and focus on the guideposts and all of these new strategies, which we're working very hard to make sure are successful. And we're increasing costs and risk for not doing this stuff. I'm not sure there are any questions at this point. Zach, is there anything that you feel we should check on for purposes of questions? Just taking a quick break here.
No, I think you're okay to continue on for right now. But as a reminder, please use that Q&A feature if you have any questions.
Thank you, Zach. Appreciate it very much. All right. So what do we lose if we don't do this? Right? What do we stand to lose? Well, formularies, those designations, those changes, step therapies. You'd be surprised how many pharmacy documents I look at that don't have exclusions, don't have limits, don't reference step therapy, don't talk about any funding or alternative funding sources. We want to steer people toward networks or certain supply lines. We want to use therapeutic centers. We want to potentially do certain generic strategies and the implementation of these innovative solutions. And I say innovative solutions, and our broker partners and our Employers Health Coalition people on this phone are all they're nodding, because everything about the approach that they take every day, Employers Health Coalition has a bunch of pharmacists on staff, and they're always working with clients and thinking about these innovative solutions. In fact, I think that was one of the slides that Zach showed at the beginning of this, was talking about new innovative solutions. And the idea is we have to document it. Of course, we mentioned DOL can penalize. We mentioned the participants can request it, and you have to produce it. And they are often requested when a lawyer is trolling around for you. And again, we lose the right to control. We lose our management. We lose all the smart, innovative things we're trying to do. And we can potentially create risk and exposure. And I always think of, the relationship that we have with our end user plan sponsors, our relationships with our broker partners. We don't want anybody getting in trouble. And so when we think about the need, and we think about why really we don't see good, strategically designed, problem-solving, constructed documents, well, obviously we talked about the fact that PBMs traditionally hadn't done it. And they're challenging to construct, right? It takes time and effort to do it. It takes money. And historically, the government really hasn't paid much attention. Well, that's totally changed. Historically, there's been limited patient aggressiveness, and that's really changed. I've seen even in fairly well-documented cases where participants have been complaining that a particular drug's not on the formulary or it has been removed from the formulary. And they're getting more sort of radicalized and involved, and their physicians are getting more involved in complaining about it. So that's definitely changed. And of course, this plaintiff lawyer thing. is also paying. And so it's one thing to come to everybody and say, okay, there's this big problem, now go ahead and solve it, which I think would be kind of mean. So I'm pleased to tell you that while I've identified this great problem, we also have a solution. And I want to talk about this solution and talk about the approach to the solution. And the goal here is to let everyone understand that we've got you covered here, right? Especially if you're going from nothing to something, we definitely have you covered here. A few years ago, it was actually closer to 3 years ago at this point, I had been working with Employers Health Coalition over the years for probably over 2 decades. I'm dating myself, but I'm an old ERISA guy at this point. And I had met with management, we're talking about things, and I had the EZ ERISA company that does, it's a sister company of the law firm, and we do documentation compliance, and we focus on relationships with group benefits brokers and consultants, and help them provide wrap documents and the like. And we had this discussion, and I said, I'm seeing many more occasions where people are interested in actually having documentation for all these new pharmacy strategies we're putting into place. I have the capacity to build this, but it will take a year, and I don't even want to tell you how much. If I build this, will you come? And the Employers Health Management said immediately, yes, absolutely. We know this is important. We will value this very much. And so we decided to go ahead and take that risk and build what is in essence our online support system for creating these documents for our clients. And the EZ solution prepares a robust plan document and summary plan description in a unified form. We can do this very quickly and easily for you on the website tool. The EZ ERISA team coordinates with the Employers Health team to be able to do this. We will be intaking in a step-by-step process the information that you as broker consultants or end user company sponsors produce to us, so that we can add in the basic information, but we can add in the more detailed and complex information. Schedules of benefits with multiple different rules, schedules of benefits with special rules, specialty drug, orphan drug, other types of strategies can all be properly documented. The rules that our pharmacy benefit managers have are all basically ready to go. They're already templated so that we can have those required appendices available to the end user. One of the advantages here is, as an ERISA lawyer for a long time, I can tell you that if my client says, draft me an ERISA document from cold scratch, you're looking at 5 figures of cost minimum, and you're looking at many, many weeks, if not longer, to get the document done. That's the way it works. It takes time and it takes effort and it takes a lot of money. This takes a lot of those pressures out of the system. And we have the capacity to produce a fully compliant document very quickly. If somebody got off the call today and called up their Employers Health Coalition partner this afternoon, and I'm not suggesting that you all go ahead and do this, but I'm saying that if somebody had an urgent need, we could have a document to you by tomorrow afternoon if we have the data that's necessary. We enter the data. We have a team, a really great team internally at Employers Health Coalition that is participating with us in assisting clients. Dozens and dozens and dozens of Employers Health Coalition clients have already approved and adopted this document format. Many of our broker friends and consultant friends have taken a look at this and have approved it. Many of our clients have sent it to their lawyers and have approved it. And especially knowing where you're coming from and where you're going, the reception for the product has been very, 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 very high. And people are pleased that we're able to get this done efficiently and quickly, taking in the data. We include robust information about your pharmacy benefit manager. We include robust schedule information. So we have our eligibility and entry dates and who our eligible employee classes are and who's paying for the coverage. And are there any spousal benefits, and are there maximum out-of-pockets, and do we integrate those maximum out-of-pockets with the group health plan, or do they accumulate with each other? All of the kind of details that you would expect to see. So I just want to cover this a little bit, anticipating some questions from the group. Well, how does this work? So it's pretty simple. Employers Health Coalition and its representatives and internal teams will reach out to our brokers and consultants and inquire as to the product, as to whether you want to have the document drafted for the end user customer. Once the broker or team consultant person says yes, the teams will prepare a draft. There's no cost or obligation to see a draft. The hope is you're going to say yes because you would be interested in reviewing it, but it will prepare the draft for you. The internal team may do it, the EZ ERISA team may do it, or they may work on it together depending on how robust and complicated it may be. Most of the data that we need is already available to the brokers and consultants or to the employer's health team because of our relationship with the pharmacy benefit managers. Occasionally, some additional information is necessary to be gathered. A review draft will be prepared and it will be shared for review, and final changes that may be necessary can be made, and the document is then issued for adoption. The invoicing is a $2,000 fee that it will be charged by Employers Health Coalition, and it can be coordinated with PBM available dollars so that maybe you don't have to pay anything for it, and that is a subscription for a year. The document is periodically updated, and any changes that you may make on a year-to-year basis or even an interim change are very easy and quick to make. So how do you include our details and the things that are sort of unique to our plan? In most instances, Employers Health Coalition has the plan details that you have for your specific plan and or can obtain it quickly from your brokers or consultants. And we would import all the basic information, identification of sponsor, identification numbers, and the basic legal information. And then we'll insert all of the schedule information. We're talking about eligibility, entry dates, who pays for coverage, spousal issues, limits, accumulations, et cetera, the brand specialty limitations, special rules, all the PBM special rules go into it as well. So continuing with some of the detail, we insert the PBM's data. We'll insert any of the PBM required language. We talk about any participating employers. If you're in a large coalition of companies, affiliates, many of them, many specific different entities participate in your your group health plan. We can do it as a group plan, including the participating employers, or you can have separate ones depending on how that's structured. And any other special rules or programs or strategies can be properly documented and incorporated in the schedules and appendices to the plan. And so if there's override language or there's any special clarifying language, this can all be entered. In essence, you can enter all of this information into your plan document set. How do we modify existing document language if we prefer or need to? So in essence, as I said before, you can add clarifying language, you can add special rules, you can add your initiatives, and there's a location for doing all of that, including an override. If you don't like a particular exclusion, you can do an override. A lot of the core document language stays the same. And the reason it stays the same is because sometimes we modify the document for compliance with laws and we update it. And by the way, during the year, you can have as many copies of it as you want. If we update the document, we would show you would be advised that we're updating the document. We put your special rules in a slightly different location within the document, and you could have whatever you want there. But we do that so that your special rules can be changed without changing a lot of the core language, so that when we do update the document core language, everyone is entitled to get that update. But to be clear, you can tweak or change any documentation you want in the appendices or other places in which we provide for you to do that. And it's not hard to do. And we take in comments frequently from folks that are saying, well, we understand that your exclusions are based on the formulary, but we would rather you not have this as an exclusion. Well, we can put in a rule that says this exclusion does not apply, or on occasion, not many, we have an additional exclusion that we want to add, which can also be done. So is this right? Does this work for us? Yeah, I would say undoubtedly yes. I think the first question is, what do you have now? And if you have sort of what we've been talking about, which is really not going to cut it, then this is a fast, low-cost, full and complete solution to the problem that we face. Certainly, if you have capable ERISA counsel and the time and the money to go do it that way, you should definitely do that. So what I'd say is, no matter what, everyone should have compliant documentation that covers the basis, covers the required PBM rules and everything that is necessary to present, control, manage, and solve problems of our pharmacy management and controls through good documentation. But this will be a low-cost, full, complete, and very easy to do process, because in essence, our teams will do all the work. We'll present to you for review. When you're done, you like it, we're finished. And so that, in, I guess, in about 51 minutes, is sort of a good overview with some detail of what we're prepared to do, why we're prepared to do it, why we think everyone should do it, and exactly how this works and how it all comes together, in essence, to support our broker consultants, our end user plan sponsors, and all of the constituents within the employer's health family in a coordinated effort to be able to not do just what's required from a compliance perspective, but also to build around that, wrap around that, the strategies, the required management tools that we're putting into place to solve the problem of we need to be doing a good job presenting, managing, and delivering our group pharmacy benefits to our constituent employees. So with that, this is the question slide. So Zach, any questions coming up, or have I been supersonically clear today?
Well, I think, your FAQs certainly covered a lot of it. I do have a few questions that have come in, though, so luckily we have a few minutes left. So I guess this one's probably an easy one. Can we integrate our pharmacy SPD into our medical SPD, or why would you suggest that we separate it out?
Well, that's a really good question. So this design is to have a separate prescription drug benefit document that is self-contained. The reason that you would want to try to include it would be that there'd be one source. But in reality, if you have a separate PBM from your third-party administrator, so for example, if you're using Anthem or a Blue Cross entity as your third-party administrator and you're using CVS Caremark for your PBM, you really do have two sources. The other thing is that a well-constructed pharmacy benefit document is actually kind of big. And already the medical certificates of coverage, those medical booklets, are already kind of big, right? Meaning there's lots of words, 70, 80, 90 pages, 100 pages. And, if you're going to combine it into one, it could be a little overwhelming. And so what we see in most cases is even when people try to add it, they don't do a great job of it. And many of the TPAs won't. If you're not using their pharmacy stuff, they're not going to add it. But if you are using a more progressive, thoughtful TPA who thinks they can add it, and we've seen a couple of these forms, they don't kind of add everything, because sometimes those group medical plan documents that they're using don't have a lot of the pharmacy in them because they're designed to be separate medical plans from pharmacy plans. So the recommendation is to have it in a self-contained separate document because A, you're not creating this massive 200-page document. B, this document is very easily managed, manipulated, updated, and changed. I mean, literally, if you want to change an entire supply line, you want to change a pharmacy benefit manager, it's minutes. Our teams can put this document together for you in less than 45 minutes if we have the data. I've seen it done in less than 30, and there's a lot of detail. So I think the idea is it's probably best for all concerned to keep it separate and make sure that all the pieces parts are there.
Thank you. So a little bit more on the pricing of it. So what exactly is included in the $2,000 subscription? Can you talk about the extent of the legal support involved, the level of customization that's allowed in the system?
So first, my hope is that your PBM is supporting it through some of the dollars that are available there, which makes it a little bit easy. In essence, you're going to get the document prepared for you by the internal teams for your review. We'll make any adjustments and updates. We'll incorporate your PBM special language, and this is an annual subscription. And during a particular subscription year, the document can be changed as many times as is necessary to produce the document. If you have mid-year changes, we can update those mid-year changes and publish them out very quickly for you to use. Periodically, in fact, the document just got a scrub within the last 60 or 90 days. And within that period of time, we did some internal document updates. And if there are any document updates that we think everybody really, really needs to have, so some major change in the law, we would let everybody know. We'd let the brokers and consultants know that we're pushing out a version that we really need everybody to republish. And it doesn't cost you anything for our monitoring and maintenance of those terms and for republishing the document or updating the document for any particular reason. And so in essence, it's fast, easy, lower cost, one-stop shop, presenting the document, working with you and your broker consultants, our broker consultant friends, and working with the end user to get the document core and all of the details there for you, and to provide any updates that are necessary. And if you don't change anything, you don't have to resubscribe, but most of our constituents would want to resubscribe in order to make sure that their documentation is updated.
How often do we need to update the SPD, and what type of change, plan design change, what level of change requires an update to the SPD?
That's a good question. Thank you for that question. So the summary plan description rule was actually put into place for pension plans. It really wasn't thought about for purposes of welfare plans, because the rule says you have to publish out a summary plan description every 5 years. And if you do a modification, that modification is due 210 days following the close of the plan year in which the change was made. So if you guys are designing your plans right now, and you put into place all these cool, innovative solutions with a great PBM, you're not required to issue the summary plan description until like next September. Well, for a calendar year plan, that would be kind of nuts that you don't have the booklet. Now, sometimes we have to wait. I used to wait for Aetna booklets for months, and I get it. You don't always get your insurance books or your TPA books fast enough. But delivering them out in September based on an update that was done effective January 1st kind of makes no sense. And so what is all the required information that's in here really is going to be refreshed every year. Is it possible you make no changes? It's possible, but unlikely. If you're changing copays, deductibles, supply lines, PBMs, adding an innovative feature, whatever those changes may happen to be, you want those in the documentation, updated, whenever those changes take effect. It's not common that we see a lot of mid-year changes, but we want good language on formularies because formularies do change. And so if we have good reference points to formularies, somebody needs to go to the formulary to see if their drug is there, that's really important also. So what we try to encourage folks to do is, as you're figuring out the plan design, we can participate in that process. You can finalize it. Our general rule is we try to finalize it within the first quarter of the year in which it applies. And if we have the data, we can do this fairly quickly. You don't have to wait months and months and months. As soon as we can get you into queue, we can get that document updated. And so if you think about the fundamentals, those are the things that are really in here. And those are the things that if those fundamentals change, an exclusion. You want to issue an exclusion. You want to update with an exclusion. Publish that out. It's easy to do, easy to update. And once the core is there, updates take just a matter of minutes. That's one of the advantages of having this computerized technology savvy approach.
Great. Thanks, Jeff. All right. I see that we are out of time for today. So thanks again, Jeff, for joining me this afternoon. And thank you to all of our attendees for sticking with us. And please remember to fill out the survey when you exit today's webinar. And make sure you check your email for the recording of today's webinar. That'll be sent again tomorrow. So thank you all, and we'll see you all soon.
Thanks, everybody. Appreciate it. Thanks, Zach. Thanks, Employers Health.